Yes, sir.
Okay, right.
Good evening, sir.
Mm.
My topic for presentation is anatomy of epidural space and its anesthetic relevance. Epidural space is otherwise known as the peridural or extradural space. Epidural space is not an empty space. It surrounds the dura mater from the foramen magnum to S2 or S3 where the dural sac ends. Here it is a potential space within the vertebral column outside the dura mater. Here the boundaries of the epidural space are anteriorly it is covered by the posterior longitudinal ligament and the vertebral bodies. Posteriorly it is covered by the ligamentum flavum and the lamina and spinous process of the vertebra. And laterally it is covered by the vertebral pedicles and the intervertebral foramina through which the spinal nerves and vessels exit. Medially, it is formed by the dura mater, which is a tough fibrous membrane surrounding the spinal cord and it's covering meninges, arachnoid, and pia mater. And regarding the contents of the epidural space, it contains various structures which is crucial for its function and relevant for the epidural anesthesia management. And the main contents are loose areolar tissue, loose areolar connective tissue, epidural veins also known as Batson's venous plexus, spinal nerve roots, lymphatic channels, small arteries, fibrous bands. The regarding loose areolar connective tissue, this fatty connective tissue loosely fills the space where it provides a cushion for the dura mater and allowing the spread of the injected solutions. And the amount of fat varies with the age and body habitus. It is more in younger individuals and the fat is less in the elderly. And regarding epidural veins, this is a prominent network of valveless, thin-walled venous plexuses that runs along longitudinally along anterior and posterior aspect of the epidural space. It has numerous interconnections. They drain blood from the spinal cord and the vertebral column. And regarding its clinical significance, the presence of Batson's venous plexus makes inadvertent intravascular injection, which is a common complication during epidural procedures. Venous plexus become engorged in conditions where the intra-abdominal pressure is increased like pregnancy, obesity, etc., thereby reducing the effective volume of the epidural space and increases the risk of venous puncture. And regarding spinal nerve roots, as the spinal nerves exit the dural sac, they traverse the epidural space laterally before exiting the intervertebral foramina. The nerve roots are the primary targets for local anesthetic blockade during epidural anesthesia. Regarding lymphatic channels, these are less prominent, but the lymphatic vessels are present within the epidural space. It contributes the drainage of CSF and other interstitial fluids. And regarding small arteries, they also supply the dura and surrounding structures. They are also less prominent than the venous plexuses. And regarding fibrous bands, they may be fibrous septa bands, most commonly posteriorly, which partially compartmentalize the epidural space. It also influences the uniform spread of the local anesthetics. And regarding the clinical significance, the epidural space the potential target for epidural analgesia and anesthesia, where local anesthetics are injected to block the spinal nerve roots, where it provides regional anesthesia for surgery or pain relief, mainly in labor analgesia and thoracic surgeries, abdominal surgeries, and major surgeries and lower limb surgeries. It is most commonly used. And regarding the depth of epidural space in different vertebral levels, the lower cervical, it is up from 1 to 2 mm. Upper thoracic, it is 3 to 4 mm. And mid lumbar is 5 to 6 mm. And the lumbar epidural space is widest. And it is the preferred site of blocking the nerves. And regarding the fat layer, it is the reservoir of lipid soluble drugs. And this fat layer affects the onset and duration of the block. And regarding the factors affecting the spread of local anesthesia, the volume of drug and the site of injection, patient position, age, pregnancy, epidural fat, and intra-abdominal pressures, these all affect the spread of the local anesthetic agents. And regarding the complications related to epidural space, accidental dural puncture is most common, epidural hematoma or abscess, and total spinal anesthesia, intravascular injection, and patchy block is common, and nerve injury is most common. And various methods to identify the epidural spaces. The loss of resistance technique, either by using arrow saline, which is the gold standard method and most commonly used. And other methods are hanging drop method, ultrasound guidance method, which shows real-time guidance, and nerve stimulator technique, and epidural pressure waveform analysis, and capnography via epidural catheter, and fluoroscopy or contrast studies. And fluoroscopy is used in mainly pain clinics and interventional settings. And ultrasound is gaining a popularity in difficult anatomy or obese patients. Thank you, sir.
So is caudal epidural space also included in this? You said epidural space and extends from the foramen magnum to
Yes, sir.
coccyx, isn't it?
Yes, sir.
So caudal epidural is an important component of epidural space, and it has a very important indication in pediatric
Yes, sir.
anesthesia, isn't it?
Yes, sir.
So
Yes, to yes,
that
sir.
has to be included in your
Okay,
answer.
sir. Sure, sir.
And so first you can start by saying that epidural space can be compartmentalized like cervical, thoracic, lumbar, and caudal or sacral. Okay.
Yes,
So if you classify like that, then it will be easy. What are the indications for cervical epidural? Have you ever seen a cervical epidural being given, or have you seen a videos how a cervical epidural is given, which space they will inject introduce the needle?
not
Any of the
seen, sir.
seniors? Huh? You have not
Not
seen?
seen. Yes, sir.
Kamal, have you seen a cervical epidural being given?
For neck pain, sir.
It is mainly practiced by the pain physicians only. Okay, for cervical spondylosis and the shoulder pains, they use this technique for doing pain relief. But they have tried the cervical epidural for thyroid surgeries, okay, where they anticipate difficulty in airway. They have done surgeries and then cervical epidural that blocks all the nerves that are coming. So that is the important, of course, not very frequently practiced. Then thoracic epidural. What are the advantages of thoracic epidural? Which are the indicate? What are the surgeries which are can be done comfortably under thoracic epidural?
Abdominal surgeries can be done,
Upper
sir. It
abdominal, but
provides
organ
segmental
wise,
anesthesia.
segmental is subarachnoid segmental. Okay?
Yes,
Epidural,
sir.
you can do polycystectomies in high risk patient with both
Yes, sir.
cardiovascular as well as lung comorbidities.
Uretroplasty.
Uteroplasty
Uretroplasty.
is lower down. Thoracic
Yes,
epidural
sir.
is more for pancreatic and liver involved surgeries, and it can be done as a standalone technique or it can be used along with JEA for intraoperative and postoperative pain relief so that you can reduce the quantity of opioids that are given. You would have seen majority of the
Yes,
gastrointestinal
yes, sir.
surgeons prefer to have an epidural, isn't it?
Yes, sir.
You have a good department there doing liver transplant and gastric procedure.
Trans.
So they do thoracic epidural as a intraoperative supplementation as well as post-op pain relief. Okay? Then lumbar epidural is more an ideal technique for obstetric analgesia. Okay?
Yes, sir.
So obstetric analgesia, they use it. How is that very low concentration? What is the concentration that you give for producing what is called the walking epidural? Have you heard of the term walking epidural?
Yes, sir. In
Ah,
uh, labor patients.
hmm.
Um,
When you want to provide obstetric analgesia, what is the
yes, sir.
concentration of local anesthetic? Which local anesthetic is preferably used and what is the concentration? And why such a low concentration is used? What are the various concentrations available of a long-acting local anesthetic agent? Name first of all a long-acting local anesthetic agent.
Bupivacaine.
Bupivacaine. Are you using bupivacaine or some other more safer drug in bupivacaine category?
Levobupivacaine.
Levobupivacaine. Why do you prefer a levobupivacaine over bupivacaine? What is the original bupivacaine called?
It levobupivacaine is less cardiotoxic.
Less cardiotoxic. Okay. But what is the original bupivacaine called as? Is it a mixture of both levo and dextro form?
Yes, sir.
So if a drug has got both levo and dextro, what do you call the drug?
Enantiomer.
It is a racemic mixture.
Racemic mixture.
It's a racemic.
It is a racemic mixture. Okay. Any drug which has got both the dextro and levo rotatory forms of the drug is called the racemic mixture. And this racemic mixture has more potency for cardiac toxicity. If you produce a local anesthetic toxicity, it takes a longer time to dissociate from the sodium channels in the cardiac myocytes. So the toxicity time is prolonged. So they have come out with the levo form. They have isolated the levo from the dextro, and we have this levo anavin, which is levobupivacaine, which is the preferred drug because of its less cardiotoxic effect. And what are all the various concentrations that are available or marketed? You have 0.5,
0.5, 0.25, 0.125, 0.625.
0.125, is it available commercially?
No,
You
sir.
have 0.5 and 0.25. You have to dilute further if you want.
Dilution on
Okay?
dilution.
So 0.25 you can dilute equal volume, it will become 0.125. And if after diluting again, if you dilute it with another equal volume of saline or water, it will become 0.0625. Okay.
Yes.
So that is the lowest concentration that can be used
Yes,
for producing just analgesia alone without motor blockade, so that the patient can ambulate and go to the restroom and attend to their nature's calls and all those things. At the same time, if they develop labor contractions, they can help the physician by pushing also, by contracting the muscles. Okay, that is what is called the walking epidural, using a very low concentration just to block the sensory nerves to alleviate the pain, but preserving the motor function. That is the importance of lumbar epidural. Okay? And of course, we use that for routine hernia surgeries, hysterectomies, both for intraoperative as well as postoperative pain relief. But you should not forget about the caudal epidural space also, which is very, very useful in majority of the pediatric surgery done infraumbilical as well as sometimes even the upper segments. And you have to talk about the Armitage formula of usage of these agents and the Scott formula. Have you heard of Scott formula for epidural dosage calculation?
I couldn't hear the name, sir.
Scott, S-C-O-T-T, Scott formula. Have any one of you heard that name? Armitage is the commonly used formula. What is the dosage recommended in Armitage formula?
5
ml per kg of 0.25% for perineal and intraumbilical below inguinal surgeries. Okay.
Yes.
And 0.1 ml, 1 ml per kg of 0.25 for intraumbilical or up to L1, and 1.25 ml per kg of less than 0.2% for higher levels of thoracic or upper abdominal surgeries. Okay, these are the three different doses that have been recommended by Armitage. One is 0.5 ml per kg of 0.25%. Then next is the for higher level 1 ml per kg of again 0.25, 1.2 we have 5 ml per kg of 0.2 or less than 0.2 for upper abdominal or thoracic surgeries. So the advantages in pediatric patients, the drug can extend and go up to the thoracic level. You can even pass a catheter up to thoracic level, and they have reported cases of thoracotomy done with a caudal anesthesia with a catheter in situ. Okay? So that also is an important part of the epidural space. And what are the complications of epidural anesthesia? When you say relevance, you must say about the
Yes, sir.
complications of epidural anesthesia also.
Dural puncture and any
Ah,
catheter migration is most common, and the
yes,
intravascular injection is most common. Epidural
okay,
hematoma or
very
abscess
good.
formation, and
Hmm.
any neurological injury. Patchy block is most common in epidurals.
Fantastic, very good. And any relevance of this Baston's valvular structure? You said the Baston's plexus is a valveless venous
Yes, sir.
plexus. Normally,
Yes, sir.
veins have always are having a valve to prevent the backflow. But the peculiarity about the venous drainage in the spinal canal is the Batson's valveless epidural plexus. So does it have any significance with the malignancy?
Prostate, sir.
Huh? Prostatic
Prostate.
malignancy can spread to the vertebral column and produce very severe back pain, neurological deficits. Okay, so that is a
Yes,
very
sir.
important relevance of the epidural Baston's plexus also. Okay,
Yes, sir.
so I'll just show you what are all the points that you have to add to your answer.
Yes, sir.
The anatomy of the epidural space and its relevance to anesthesia. Boundaries. First, you must describe anatomy question. You should always say the boundaries of your epidural space. Superiorly, it is diffusion of spinal and periosteal layers of dura mater at the foramen magnum level. So the epidural space, the superior aspects, ends outside the cranial cavity, whereas the subarachnoid space is continuous with the subarachnoid space in the intracranial cavity also. So the major difference is epidural stops. So when even if your drug ascends maximally, it will only produce a very high spinal block and not a total spinal. Whereas what is the difference between high spinal and total spinal? Supposing when you are attempting to produce an epidural analgesia, you inadvertently puncture the dura, but you fail to notice the seepage of CSF and you inject the entire drug. Everything goes into the subarachnoid space. In another case, the dura is not punctured, but you use a large volume, thinking that it is required. You give 30-40 ml, and it goes up to the foramen magnum. What will be the difference in the clinical picture?
Uh, in total spinal, there will be cervical involvement or phrenic nerve involvement.
Cervical
Uh,
involvement will be here also. Up to foramen
yes,
magnum
sir.
means all the cervical nerves also will be blocked. High
Uh,
spinal also, isn't it?
yes, sir. Both will present as a same bradycardia and
Same
hypotension.
only. No difference at all. In subarachnoid, the drug is ascending into the cranial cavity also because this
Yes,
subarachnoid space extends or is continuous with the cranial subarachnoid space, isn't it? The CSF is flowing from the lateral ventricles all along the cranium, and then the same CSF only travels down into the vertebral canal. So the drug which mixes into the CSF by accidental subarachnoid injection, will it not travel intracranially?
yes, sir.
So if it goes to intracranially, which is the part of the central nervous system which is affected first? What is the continuation? Spinal cord continues from where?
Uh,
Medulla.
No.
Medulla, continuation of pons and medulla is your spinal cord. So
Mm.
if the drug goes to medulla and pons, we studied last class about the respiratory control.
Respiratory depression, sir. Depression.
Patient will have respiratory arrest
Diaphragmatic.
first.
Yes, sir.
So whereas it will not happen in high spinal epidural, even if the drug travels up to the foramen magnum, it cannot affect the centers, respiratory centers present in the medulla and pons. So patient will continue to breathe, but he will have severe hypotension because all the thoracic sympathetic outflow is completely blocked. He may have a hypotension and bradycardia, but patient may still be breathing in high spinal. Whereas in subarachnoid total spinal, the drug will go and block the respiratory centers at medulla and the pons directly, and patient will immediately have a respiratory arrest also. He will stop breathing. Okay, so that is the very, very important differentiation between these two. So that is the importance of the superior boundary. Okay, inferiorly it goes up to the sacrococcygeal membrane. Then anteriorly it runs along the posterior longitudinal ligament, vertebral bodies and disc, because it is a circular covering. So it is has a anterior boundary. Posteriorly, ligamentum flavum, capsule of the facet joints and laminae are all the boundaries of epidural space. And laterally, the pedicles and the intervertebral foramen. The space extends also. That is the reason why when you inject the drug, it not only travels along the potential epidural space between the two layers of this dura, but also seeps along the spinal nerves which are going there. So laterally, they will also spread there also. So it has got superior boundary, inferior, anterior, posterior, and lateral. So these are all the boundaries. What are the contents? Next thing, fat, dural sac, spinal nerves, vessels, and connective tissue. Now, division of epidural space according to the location is the next thing which we have to know. So, cervical from foramen magnum to C7 lower margin is the called the cervical epidural space. And thoracic epidural starts from the lower margin of C7 vertebral body and goes up to upper margin of L1. Lumbar upper margin of L1 to upper margin of sacral 1, and sacral from upper margin of sacral 1 to sacrococcygeal membrane. So what is the nerve supply of spinal canal, and which structures in the vertebral column can perceive pain? Can you answer this question? How is the spinal canal supplied? What nerves supply that? And which are all the structures in the vertebral column which are painful, which structures are painless? Is ligamentum flavum painful? Anybody can answer. Kalpana also can answer.
No, sir.
Is dura painful?
Dura painful.
Dura
Dura
painful.
is painful. Yeah, when you
Painful.
do a
Painful.
VP shunt insertion under local anesthesia, the three structures which are painful are: one is the skin, second is the periosteum, third is the dura. If you make a burr hole on the bone, it doesn't cause a pain, but the periosteum is painful. So you have to inject subperiosteally, then you can easily drill through the bone. And again, periosteum is sensitive, so we have to inject local anesthetic there also. So the anterior dura is heavily innervated. So the dural space towards the vertebral body and the uh, uh, posterior longitudinal ligament, that is quite heavily innervated and painful. The posterior dura is less painful because it is partially innervated, and the nerve supply of spinal canal is derived from branches from the sympathetic chain as well as the sinovertebral nerves originating from the rami communicantis. How many of you know what is this rami communicantis? How many rami communicantis are there? And what is the purpose of that? How many types of rami communicantis are there? Once the spinal nerve
White
comes
and
out of
grey, sir.
white rame and
White
grey
and
rame.
grey
Grey
ramen.
ram.
What is the purpose of that?
They
It is
carry
to
green ganglionic as well as
it is
post
mainly to traverse the sympathetic nerves, spinal sympathetic nerves. Okay, so they travel along that and sometimes they come back. So those are the ones which are causing the pain. The periosteum is pain sensitive, but ligamentum flavum is totally insensitive. That is why when you puncture the ligamentum flavum, patient will not have pain. But if you go and hit a bone and try to inject there, periosteum of the bone is painful. So if you are in the wrong direction and go and hit the lamina or the spinous process or the body, then patient will complain of pain. Whereas if you are puncturing the ligamentum flavum zone, you will not have any pain. Now coming to applied anatomy, epidural anesthesia, all thoracic, lumbar, sacral are used for surgery as a standalone sole technique or as a supplemental technique for general anesthesia. Then epidural steroid is given for chronic neuropathic pain relief. Epidural blood patch is done for postdural puncture headache if conservative measures fail. And labor and postoperative pain management done by placement of catheter in the epidural space, which can be topped up manually, intermittent bolus injections, or by patient controlled analgesia can also be used. And the anatomy and indications of caudal epidural is very important in this question because this is a very commonly used technique. So the caudal epidural space is the lowest portion of the epidural system and it is approached through the sacral hiatus. And sacrum is a triangular bone, is a fusion of all the 5 sacral vertebrae from S1 to S5. And it articulates with the L5 above and the coccyx below. The contents of sacral canal are terminal parts of the dural sac which end between the S1 and S3 level, S1 in adult and S3 in children. And the 5 sacral nerves and coccygeal nerves making up the cauda equina are there. So the sacral epidural veins generally end at S4 but may extend through the canal and they are at risk of catheter or needle puncture. And the phylum terminale, the final part of the spinal cord, which does not contain nerves, this exists through the sacral hiatus and is attached to the back of the coccyx. And epidural fat, which changes from loose texture in children to fibrous close mesh texture in adult, and it is different is to the predictability of caudal spread. So in children, you can definitely assess the spread because of the loose nature of the fat, whereas it becomes very unpredictable in adults, and that is the reason why caudal anesthesia is not very popular in adults except for usage by the pain physicians who use it for coccydynia and other painful conditions in the lower back. And what are the indications and contraindications for epidural anesthesia? Indications are for any anesthesia and analgesia below the umbilicus or for obstetric analgesia or chronic pain problems. Contraindications, infection near the site of the needle, coagulopathy and anticoagulation, and congenital abnormalities of the spine or meninges like earlier meningocele or spina bifida, etc. Pylonid also is there. And patient refusal is also one of the important contraindications. And what are the drugs chosen and at what dosage for this caudal epidural? Usually you use lignocaine 1% or bupivacaine 0.25%. You can use this for adult also for a blockage of lumbar or thoracic also. And because most of the time we use it for longer duration, the most preferred drug is bupivacaine or levobupivacaine. And ropivacaine also is being used very frequently nowadays. Now, Armitage formula for usage of this for children is 0.5 ml per kg for lumbosacral block 1 ml per kg for thoracolumbar block and 1.25 ml for mid-thoracic block, but the concentration should be reduced to less than 0.25. So he recommends 0.25 bupivacaine for block up to a maximum usage of 20 ml based on the body weight. If you want to use the drug for a higher block like mid-thoracic, you have to use a larger volume, but you reduce the percentage by adding one part of your normal saline to 3 parts of your 0.25 bupivacaine. So it will form a total of 4 ml. So 1 ml of normal saline with 3 ml of 0.25 bupivacaine. So this 0.25 in 3 ml, how many milligrams will be there? How do you get 0.19 percentage? Ranjini.
Yes,
So when
sir.
you say 0.25%, how many grams of the drug or milligrams of the drug will be there in 1 ml?
2.5 mg.
2.5.
2.5 milligram per ml.
Yes, sir.
Okay. When you say 0.5, it is 5 milligram.
0.5.
When you say 1%, it is 10 milligram. That is the easiest way to remember.
sir.
Any 1%
Yes, sir.
solution will contain 10 milligram of the drug in 1 ml. 0.5% will contain 5 milligram in 1 ml. 0.25 will contain 2.5 milligram in 1 ml. So you have 7.5 milligram when you take 3 ml of the 0.25 and you are adding 1 ml of saline. So 7.5 divided by 4. So automatically it comes to roughly 0.19%. Isn't it? 18 into
Yes,
4
sir.
is 72. So,
Yes.
so that is how you calculate that. Then Scott is another person who said that Armitage formula sometimes becomes erroneous in obese children. When the weight of the child is very high, then basing that only on the body weight, it becomes erroneous. So he said you have to take into account both the age and weight. So if the child is of average weight for its height, both figure will be the same. If the child is overweight, use the figure based on age to avoid the possibility of overdose. And that is how this Scott formula is sometimes given. So this you can go through later, and based on that you can calculate the weight. And this epidural anesthesia, both given in Nagaswamy, this is a central neuraxial block. Onset is slower than subarachnoid block. Block height depends on the injection site, drug dosage or the volume that you inject. So normally you calculate at 1 to 2 ml per segment. So you calculate the number of segments you want to block, and then you, for example, if you want to do an abdominal surgery or a cesarean section, what is the level of block you want to achieve for a cesarean section?
T4, T6 level. Sir.
T4 to T6, very good. So how many segments you will be blocking? Below T4 to T6, if you calculate. So T4 to T12, how many segments? 8. Then lumbar 5. Then sacral 1. Isn't it? So 8 plus 5, 13 plus 1, 14. So that is the reason why you have to choose between 14 ml to 28 ml. Okay. So the number of segments that you want to block multiplied by 1 or 2 is the calculation of the dosage. And the advantage is it has less pulmonary and cardiac morbidity. And indications, you can do it for lower extremity, genitourinary, vascular, gynecological, or colorectal, even cardiothoracic surgery and cesarean section. Contraindication, absolute contraindication is patient refusal, sepsis or allergy. Relative contraindication, myelopathy, neuropathy, spinal stenosis, multiple sclerosis, etc. And relative cardiac aortic stenosis is the relative cardiac contraindication with the patients having a fixed cardiac output and hematological anticoagulation and thrombocytopenia. And mechanism of action is disruption of the nerve transmission within the spinal cord. So it acts at the root level of both the anterior and posterior roots when they come to form the combined spinal nerve before they emanate or traverse through the intervertebral foramen. That is the location. So the dorsal root and ganglia are all blocked there, and the speed of onset of neural blockade depends on the size, surface area, and degree of myelination of the nerve fibers. So which nerve will get blocked faster, myelinated or unmyelinated?
Myelinated.
So here you can see the
Myelinated.
block onset. Small preganglionic sympathetic fibers, B fibers, minimally myelinated, they get blocked first.
Unmyelinated is blocked.
They take unmyelinated, take a faster, the unmyelinated cold temperature, then A delta, then A beta, and A motor fibers. So that is the order in which they will be blocked. That is why we test for what sensation? Do you test for pinprick or you have to test for cold?
Cold.
Cold
It's
sensation.
better to test for cold. Okay, so that is how we must test the level of the block. And the reversal happens in the same way. That is, my motor fibers will recover first, then touch sensation will come, then pinprick sensation, then temperature, then the autonomic fibers. So that is the order of recovery also. And these are the 4 levels: cervical epidural, thoracic epidural, lumbar, and supracoccygeal or sacral epidural. And the technique that you do is prepare position, projection, and puncture. Informed consent, IV line should be there, resuscitation equipment should be ready. It could be aseptic technique with painting the area with anesthetic. Position, you can do it in lateral decubitus or sitting position. Especially obese patients, sitting is much more comfortable. And you can approach the epidural space through a midline, median approach, or a paramedian, or a Taylor modified paramedian and caudal approach. These are all the various approaches that you can do. And puncture, you advance the 2P needle. What is the full description of this 2P needle, including its tip? Is there a full name? Is there any other addition to be done for the description of 2P needle? Especially how is the tip of the 2P needle? Is it straight bevel like your regular IV needles?
It's
No, sir.
slightly curved.
It is
Well,
slightly curved. What is
Curved,
that
yes.
tip called?
Uh,
Is there any name for the tip?
Huber point.
Fantastic. Huber point. Who said that?
Myself, sir.
Kalpana.
Yes, sir.
Very good. So it's called the, why, who is Huber? Any idea? Any further history you know of that?
No,
Huber was a
person who
dental surgeon. Okay. So instead of when he was using these needles, the straight bevel needles used to go and poke the bone. The patient used to experience severe periosteal pain. So he thought, why not we just curve the tip a little bit, and he used it in dental anesthesia. And too, he copied that from him. So it is he was given the recognition for his invention, that so it is to be called as Huber point 2P needle, not just 2P needle. Okay, 2P, when he made it, we made it as like a straight bevel only, but he copied it from Huber, and it is called Huber point 2P needle. Okay? So advance the 2P needle, the stillet through the supraspinous ligament into interspinous ligament. Remove the stillet, attach the loss of resistance syringe with air saline, and with or without air bubble you can do that, and use hanging drop technique. You are not have you ever any of you tried hanging drop technique or seen being done, Ranjani?
No, sir.
Oh, it's a very beautiful technique to practice. You will see the drop of the local anesthetic getting suddenly sucked in as soon as you reach the stage. Why it gets sucked in?
Negative pressure.
Negative pressure.
The
Because of
space
the
is
negative
negative
pressure. What is
pressure.
the theory description given for the negative pressure in the epidural space? How does the epidural space develop this negative pressure? My dear? Because it communicates with the intrapleural pressure. Okay, so that is the reason why it has developed the same negative pressure which is present in the intrapleural space. Okay, and
Yes,
that negative pressure is maximum only in the lumbar because that is the widest part, as she said. In other areas, the space is so narrow that the negative pressure will not be appreciated. So, when next time if you get a chance to do a lumbar epidural, try the hanging dart technique. Okay, what you have to do is, as he said, you first inject through the, I mean, pierce the needle through the supraspinous and infraspinous ligaments, which you will feel like the cracking sound or the gritty feeling that you have, and then you remove the stillet and put one drop of local anesthetic and hold on to the flanges and gently keep advancing the needle, and once you enter the epidural space, the drop will suddenly get sucked in. Then you can attach your syringe and inject air very easily and inform the presence in the epidural space. So it's a very nice technique to follow. And then you can insert the epidural catheter in case you want to give a continuous spinal in an epidural, or you can give a single bolus dose also for short surgeries or in cases patients are coming as a daycare procedure and you want to discharge them, you can use it as a single shot treatment also. Okay. So can anyone tell me what is the name of this sort of chart which has all the pictures and the writings called?
Flashcard, sir.
It's called the infographics. It gives you all the information and it has the graphics of pictures. So it is called the infographics. Okay. So that's about the epidural anesthesia. Right. Who is presenting next?
myself.
Hmm.
My topic is blood supply of spinal cord. Coming to the arterial supply, it is supplied by three longitudinal arteries and it is reinforced by the segmental artery. Coming to the longitudinal artery, there is one anterior spinal artery and two posterior spinal arteries. These anterior spinal artery is formed by the union of branches from the fourth part of vertebral artery near the medulla, and it descends in the anterior median fissure along the whole length of spinal cord, and it gives cervical branches and it enters the spinal cord. The area supplied will be anterior two-thirds of the spinal cord, which includes anterior horn cells, lateral horn cells, corticospinal tract, spinothalamic tract, and anterior and lateral white commissure. Coming to the posterior spinal artery, it has a two arteries. It arises from either vertebral artery or posterior inferior cerebellar artery, which is again a branch of vertebral artery, and it runs along the posterolateral sulcus near the dorsal root. The area supplied will be posterior one-third of the spinal cord, which includes the posterior column such as gracilis and cuneate fasciculi and posterior horn cells. And segmental arteries, also known as reinforcing arteries. These segmental arteries arise from the different segments of the vertebral canal through intervertebral foramens, which include vertebral artery, ascending cervical artery, posterior intercostal arteries, lumbar artery, as well as lateral sacral arteries. And these divide into anterior radicular artery, posterior radicular artery. Sometimes it enlarges and reaches the spinal artery as segmental medullary artery. Artery of Adams-Stevens is also known as a greater anterior radicular artery, is the largest artery. It arises from the left side, posterior intercostal artery from the levels T9 to T12. It supplies the lower thoracic or lumbar and sacral spinal cord. Um, it also supplies the lumbar enlargement, which would be at the level of T4 to L1. The artery of vasocorona is a pile arterial network surrounding the car. It connects the anterior and posterior spinal arteries, and it mainly supplies the periphery of the spinal cord. Coming to the venous drainage, um, there are intrinsic spinal veins as well as extrinsic venous plexus, which enters into the systemic veins. Coming to the intrinsic spinal veins, uh, these get the venous drainage from the spinal cord tissue, such as anterior vein, posterior vein, and central vein. And these enter into the surface draining veins, such as anterior median vein, posterior median vein, anterolateral and posterolateral vein. And these drain into radicular veins, which accompany the spinal cord. Through the intervertebral foramen, it enters into the internal vertebral plexus, which is the valvulus vein, which is called would be in the epidural space, and it communicates with the external vertebral plexus as well as with the segmental veins such as intercostal veins, lumbar veins, sacral veins, and vertebral veins, and it finally enters into the systemic veins as azygous veins, inferior vena cava as well as the superior vena cava. Coming to the applied anatomy, anterior spinal artery syndrome is an important clinical condition. It is mainly due to either thrombosis or during the aortic surgery. The reason would be ischemia as well as during the trauma. The clinical features will be below the level of the lesion, there will be bilateral motor blockage and loss of pain and temperature sensation, but the proprioception and vibration will be preserved since the posterior column is spared. Infection is possible during the aortic surgery, which includes mainly the artery of Adam's usus. When it is damaged, there will be ischemia of the lumbar enlargement, which results in the paraplegia below the level and also involves bowel and bladder incontinence. There are some watershed areas of the spinal cord. Since this anterior spinal and posterior spinal arteries get narrower after it passes from the cervical level, it would be supported by the segmental arteries to reinforce the blood supply to the spinal cord segment. In the region from mid-thoracic, that is from T4 to T8, there is poor collateral circulation, hence they are more vulnerable for the ischemic region. Hence these are called as watershed areas of the spinal cord. Compression of a spinal arteries by any tumor or is there any disc prolapse, it may obstruct the radicular artery and may lead to spinal cord ischemia, which are mostly supplying over the periphery. Spread of metastasis is mainly due to this Bastion plexus. Since it is valvulus, it can easily enter into the systemic circulation. Any infection as well as can enter into the systemic circulation through this venous plexus. There is also a posterior cord syndrome, which is very rare. Lesion of the posterior spinal artery. There will be the posterior one-third will be ischemic. Hence, the clinical features will be loss of proprioception, vibration, sensation loss, and loss of two-point discrimination, as well as loss of light touch. Thank you, sir.
So when can this anterior spinal artery syndrome happen? What can produce this anterior spinal artery?
So most of the time in the ischemic changes like atherosclerosis can happen, or during trauma it is possible too.
Okay.
During
Any
aortic
surgeries
surgery, like
where
loss
you intentionally reduce the blood pressure? Are you asked to produce what is called induced hypothermia during some surgeries?
yes, sir, yes, sir.
What surgeries the surgeons request you to do intentional
These
or
large
induced hypothermia?
vessel surgeries like aortic repair and all, they will.
Mostly aortic, you are working in New York, fine.
In lower limb surgeries, they will be asking to.
No limb surgeries, they ask you to reduce the BP. I'm saying spine. With spine surgery, they request you to reduce the BP, to reduce the blood loss.
Scoliosis, sir.
Scoliosis.
Scoliosis surgery. Okay, large level scoliosis, very multiple level scoliosis surgery is the one where they request you to purposely reduce the blood pressure to reduce the term of blood loss and transfusion. Okay, one of the techniques is to do what is called the we have discussed that when we discussed about scoliosis surgery in the earlier classes. Three methods of conservation of blood is autologous blood donation. Second is acute normovolemic dilution on the day of surgery. Third is cell salvage. And fourth is intentional hypotension. But the intentional hypotension, what are the drawbacks?
The patient mostly would be in prone position. It can lead to visual loss also.
Very good. Then?
Spinal cord ischemia.
Spinal cord ischemia. Very good. Then? Can it interfere with the type of monitoring? What monitoring you do during scoliosis surgery or when you do
neuromuscular
monitoring? So evoked potential monitoring. Okay, when you do the evoked potential monitoring, that also can be interfered if there is ischemia. Okay, so we normally try to do that. Okay, so that is the. Can you add a vasoconstrictor like epinephrine to local anesthetic to prolong the duration in subarachnoid block?
It can lead to local vasoconstriction also. So we don't add.
The drug will not be absorbed faster. So can it be done to prolong? Supposing you have only xylocaine. Earlier days we used to have only xylocaine. Just a limited duration of action. So can epinephrine be added to xylocaine and injected subarachnoid to prolong the duration, just as you do when you use it for blocks in the upper limb or the lower limb blocks, like scalene or classical supraclavicular. We always use xylocaine with adrenaline, isn't it? So can that be done subarachnoid space? No, strictly speaking, no, because that will cause spasm of the single vessel which is present in the anterior aspect and which is supplying almost anterior 2/3 of the spinal cord. Okay, so it may produce a anterior spinal artery syndrome. So any local anesthetic, especially when you are using local anesthetic containing epinephrine for epidural block, any inadvertent pleural puncture will cause this blood to seep into the subarachnoid space and cause a spasm of the anterior spinal artery. That may be also causing this motor weakness. Then it may lead to medical legal issues. Okay, so it should not be added. Right. I'll just show you other things to be done with that. So blood supply of spinal cord, it's supplied anatomy. Main supply is by two spinal arteries. One spinal artery present in the anterior aspect, a single anterior spinal and two posterior spinal arteries. And the anterior spinal artery arises from the two vertebral arteries before they traverse through the vertebral foramen and join together at the base of the skull. So from there they originate, and the anterior spinal artery travels caudally downwards after arising from the two vertebral arteries. Both of them contribute one segment, and it unites together to form a single spinal artery, and then it traverses to the anterior sulcus. Whereas the posterior spinal arteries, they branch off the posterior inferior cerebellar artery most of the time, which is called the pica, posterior inferior cerebellar arteries, and they branches of, or sometimes they may branch from the pre-atlantal vertebral arteries also. So the anatomical variation that can happen is the posterior spinal arteries can branch off from the vertebral also, which also travel caudally down to the spinal cord through the two posterior sulci. and one single spinal artery, anterior spinal artery, and the two posterior spinal arteries, they are not sufficient to supply blood to the entire spinal cord. So there are additional supplementing vessels, the additional segmental arteries throughout their course down the spinal at each point of the spinal level through the intervertebral foramen. So these vessels, which additionally supply the spinal cord, they all travel into the spinal canal through the intervertebral foramen, and the segmental artery then bifurcate into an anterior and posterior radicular artery, and they feed into both the anterior and posterior spinal arteries, and they not only supply the anterior and posterior spinal arteries but also provide blood supply to the nerve roots alongside which they track. So as they are entering through the intervertebral root, small branches supply the spinal root also. So this is the vertebral artery which goes to unite to form the basilar artery. So before it unites to form the basilar artery, you can see a branch arising from each vertebral artery which immediately combines together, and this is the anterior spinal artery going to the anterior aspect. And the vertebral artery has got a branch called the posterior inferior cerebellar artery, and from each of them you find one branch coming. So they are the posterior spinal arteries. So this variation can be, it can also arise from the lower part of the vertebral artery itself. And why this anatomy is important is nowadays when you go to hair salons, hairdressers, sometimes they do the manipulation of your neck. They try to give you relaxation by turning your head this way and that way. The chiropodic movements can sometimes produce the damage to that, and patient will collapse with the time of doing it itself. And the segmental arteries run from their intercostal vessels and other areas, and they come inside the spinal canal through the intervertebral foramen, and you can see one branch going and supplying the anterior spinal as well as going to the posterior spinal arteries. So that is how the segmental arteries supply or contribute to the additional blood supply throughout the length of the spinal cord. So the main supply is from the anterior and posterior, supplemented by segmental arteries at every level of the. So the two anterior spinal and the anterior spinal arteries supply the upper cervical spinal cord as they come off the vertebral arteries before they anastomose together. So for the cervical spinal cord, before the two spinal artery branches arising from their vertebral artery, before they become single, the spinal cord supply is received from that for the upper cervical spinal cord. For the mid-cervical spinal cord, receives vascular supply by segmental medullary arteries coming from the vertebral arteries, and for the lower cervical to the upper thoracic spinal cord, the radiculomedullary arteries arising from the front of T7 to T1, either on right, left, and right. The segmental spinal arteries supply mid-thoracic region, some of the posterior intercostal arteries. So their segmental supply comes from the posterior. The largest segmental medullary artery, that is before they become radicular artery, is the artery of Adam's which is known as the greater anterior radiculomedullary artery. So this one comes at the thoracic level between T8 and L2. So branches of the left side of descending aorta. Plexus not from intercostal but descending aorta itself. Lumbar and intercostal arteries coming to the ventral side of the spinal cord to supply anterior spinal artery. So it mainly connects to anterior spinal artery because that single artery is supplying a larger portion. So this branch, Adam's twist, is a very important branch to maintain blood supply to the lumbar lower thoracic segment of the spinal cord. So delivers vascular supply a large area of thoracolumbar region that's considered as the watershed area. Branches from the internal iliac artery supply the lumbosacral spinal cord, and the venous drainage spinal cord drains via a single anterior spinal vein and single posterior spinal vein. Some books say there are three veins, but actually the three veins are nothing but the branches which are coming from inside the substance of the spinal cord outside, and then they unite to form this. So the single anterior spinal vein and posterior spinal vein is there, contrary to the single artery on the front and two arteries on the back. They drain into the internal vertebral venous plexus located in the epidural space within the extradural part. And these veins eventually empty into the external vertebral venous plexus via the basivertebral veins, and the bastan venous plexus, which drains any organ to the pelvis, including the bladder, prostate, and rectum, feeds into internal vertebral plexus. The bastan plexus do not have valves. So it is classically described as the valveless vertebral plexus of bastan. That is how it is described in the textbooks. Coming to the applied anatomy, the posterior cervical spinal procedures like doing a cervical spine fixation for cervical gastrectomy in the posterior approach for this problem in the cervical region can damage the vertebral arteries by you try to put the proximity to the transverse foramen. The thoracoabdominal aortic aneurysm surgery can lead to human spinal ischemia because of the decreasing flow in the arterial appendage. Disruption of artery leads to paraplegia also, if the lower thoracic lumbar spine becomes ischemic. The arterial appendage is considered a vertical area in the spinal cord, which is susceptible for obstruction following episodes of severe hypotension. So, if continued hypotension there for more than 40 hours during surgeries, then there is a possibility that the patient can have ischemia in the area supplied by this procedure. And this area supplied by the artery is prone to ischemia and disruption because last major artery feeding the lumbar spinal cord. It makes a classic hairpin loop upon entry into the anterior spinal artery. That is the reason why, even though it is coming directly with the communication from descending aorta, because of the hair loop bend, it may get approved. And there are generally no communication or anastomosis within the anterior and posterior spinal arteries, so making the arterial adductor easier to an end artery. And the vascular anatomy can often lead to anterior spinal artery spinal cord syndrome, the region of lumbar spinal cord, which can result in loss of motor function and sensory because it is supplying the motor and sensory tracts which are carrying the sensory. And the diagnosis of this ischemia is usually made by doing the MRI investigation, which will create what is called an owl size sign with hyperintensity on T2 active images. We can see this is the two skin areas producing the picture similar to the eye of an owl for the owl eye sign. This picture putting across by that. So this outside sign indicates that there is a ischemia of the lumbar spinal cord due to disruption in the way of arteries or the anterior spinal. And vertebral artery dissection, rare origin of stroke, occurs more often in the younger population, age just 10 or 3 years old. They can occur from blunt trauma to the neck, like chiropractic manipulation or connective tissue disease. Bastan venous plexus, well documented route of metastasis for carcinoma of prostate by heteropathogenic spread to the vertebral column and brain because of the valvular structure of the veins. During pregnancy, the extradural venous plexus can become engorged because of the pressure of the graviluteus inferior vena cava. And because there are no valves, the pressure will be transmitted back to these plexus. They all become quite engorged. This will reduce the chances of direct injection of LA drug into the veins and produce LA toxicity in epidural anaesthesia for labor pain for operator obstetric. That is, those are the patients who are more prone for this direct toxicity. And the blood will then be shunted to external venous plexus from these fractional plexus. Because of the increasing size, the veins will reduce the epidural space and also the spinal space, subarachnoid space. So drugs which are administered in pregnant women or in patients with obese conch or patients with ascites, whenever you give a spinal block, you have to reduce the dosage because when that space is narrowed to the engorged veins, that will cause a higher spread between the regular volume that you. So to prevent higher level of spread, to lessen the dosage. The epinephrine containing local drugs are to be avoided subarachnoid block that can cause anterior spinal artery because then the single spinal artery can become ischemic. Also, bilateral loss of motor function with the corticospinal tract, the same temperature tension which is carried by the spinothalamic tract. But the posterior column sensors will be preserved. However, there's an anterior spinal artery syndrome, which will be mostly motor and sensory function loss, not the position sense or vibration. And the posterior spinal artery syndrome, which is less common, results in loss of proprioception, vibration, that's due to damage in the posterior column. But patient may have the normal motor system. Prolonged hypotensive anesthetic during scoliosis surgery reduces the intraoperative bleeding, but can cause cord ischemia and also difficulty in monitoring the evoked potentials which are normally done during procedure. Great for blood supply and its relevance. Last topic. Damodaran is there.
Sir, actually, Damodaran sir is on duty today, got caught in an emergency case. So, sir will be present.